these all on?
Yeah. Yeah, you could do this. Or come down a little bit towards me. Yeah, just a bit more. Okay. Right, here's a couple of other variations on this theme. And I certainly don't want to sort of think, here are 15 techniques of traction that we do specifically. I mean, these are just variations on the same theme also. Another thing that Lewitt talks about, and certainly Olaf Evians does this, and originally I always remember that Earl was a great proponent of this in terms of women with pregnancy, because you could actually show their husbands, reasonably well how to do this, and either to kneel on the bed and just to sort of come with the legs around your ilia like this, put your hands across here, and then just sort of come up into a position like this, which is a kind of a reduction of the lordosis and a little pull here. I could either do this by kneeling on the table, or I could get the patient to the end of the table and just sort of lean back a little in that fashion here. Can you go up the table a second? Okay, I'll have to keep following you up. Okay, I'm coming into this. For me, I find it better to kneel on the table. However, I always wonder a little about my dignity getting on the table with the patient. And just imagine going before the disciplinary committee, and the next thing he did was he climbed onto the table with me, and you'll be sitting there absolutely horrified. Okay. And so I think that because three people that I really respect are doing this, this is probably a very useful kind of procedure. And I certainly have taught men to do this with the wives in the last stages of pregnancy. It's in no way going to threaten their abdomen and their baby, and just stretching up like this. And usually at that stage, men are quite willing to do things because they're feeling terribly guilty about their wife's problem. Okay. Now then, last thing that we will do, and I'll get you to turn around the other end so that I can use my decent hand at the moment, facing me, yes. Okay, we're into now looking at, we better just straighten this up so that the tape looks all right, Dave, here. Okay, is to start using some distractive techniques now in what are our standard positions. Okay, our side lying position, which is a position that we use so much for side bend, for rotation, for flexion and extension and so on. So could you just loosen your trousers, Jeff, for me? Thanks. And just come into this position here. Now there are going to be two ways, and these actually are exactly the same as trying to do distraction as a manipulative procedure as well. It's exactly the same sort of setup. Now, what I'm going to do is not to bother too much for the distractive mobilization that we're doing, as we would if it were manipulating. We'd be using our whole locking things. And when we've done about 3 or 4 techniques on, as far as locking is concerned, then you could even just superimpose this on that position. So, I need to try and resolve my forces the best I can, because I want to pull here, I want to pull there, and I want to pull or push through the hips a little bit as well. If I push through the hips, the knees through the knees, the hips will straighten and not allow me to do what I want. So my hand comes around here and holds onto the sacrum with my arm here, so that when I pull down with this and pull with the legs at the same time, you can see that I'm getting a distraction motion. Now, because of just how the setup is, with more friction on the bed than here, I'm always going to end up with a little bit of side flexion to the table. And I'm going towards that side flexion position. I would be a lot better if I could go towards the straight position instead of going towards the side flex. And so all we have to do to eliminate that is to simply take hold of the hips and pull them down a little bit. Now you can either do them with a short lever, or you can simply take this leg, which is usually the way I do it, and pull like that. So we've set it up with a little bit of side flexion to the left here. So when I pull, and most of my effort will be on the left side, I'm straightening out this left side flexion with the distraction and going more towards a straight position in the lumbar spine. So I get around here, and then I pull down like that, and that's my traction here. So my thumb of my left hand tries to stabilize the spinous process above the level I'm doing. So let me say that we're on 3 and 4, or 4 and 5. Let's say 4 and 5. My thumb will be, if I could get hold of 4 spinous process with my index finger and my thumb and hold it there, or I could fit my fingers around and pull it up there, that would be what I would do. But I can't do that. So I'm just going to stick my thumb on the top, press down to give me sort of a stabilization on that. This hand will come around, it fits on the sacrum, it gets on the spinous process. Then, with my whole body, I pull down the table like that. Okay? So that's going to be good for going from about 2, 3, 4, still pushing here, here, and here. And in examinations, you know, you sort of look at people, could you show me and demonstrate to me a distractive technique at 4, 5, and you kind of see people doing this. There's no way. You've got to be encompassed around the patient to have sufficient strength to separate these joints. Now, when we come on to the lumbar-sacral junction, okay, Olaf Evjen suggests that we should engage the sacrum with the inside edge of the elbow, and this really works well to get into this position like this. Now I can push down like that, and as a manipulation, if he was locked, it would be that sort of movement, as opposed to push, push, push. This is a very powerful movement there, but you can't do it so much. Sorry, you've got a bit of a back problem too, and I'm pulling around without thinking.
It's very powerful movement.
Okay, it's very, very efficient at that over the sacrum. Of course, Jeff gets a little sore for something he did yesterday. I wonder if it were the 3 things of going into side bend or the 150 miles that I did on my bike last night. Don't you have patients that do that? You know, I was really sore after the treatment. Well, what did you do? Well, I went and dug my garden after I'd seen you, you know, and you kind of think, and you're blaming this against your garden?
Car accident on
Yeah.
the way home.
Shoot. Yeah, and your treatment really made me sore. Okay, so we are pulling like this for higher, but on L5, S1, my forearm goes on S1 and pull. This is very nice. You can really pull down with this. So we're not going to put lots of complicated locking in. We'll just simply leave this in its kind of neutral lordotic position here and just try pulling down into distraction. So the only thing I would just remind you of is that we'll be trying to encompass this with our bodies, and we'll be pulling down with our hands like this. The only thing that we've done is to take the bottom leg and just gently pull it a little bit into side bend like this, so that when we pull down, it goes back to the straight position. Just remember that one. And then for the higher ones, we're doing this. For L5, we're doing, or S1, we're doing that. And that is very nice. I love that technique. As a manipulation for this into distraction, it's the only thing I think ever works to get that power. And so as a mobilizing, it's very, very good to get to the level where we can then do it a little bit quicker, and it's useful. Okay?
Show your higher level, your encompassing position.
Yes. Just around here, my arm's on here, my leg, this part of me is pushing down like this. So it's like the whole body is going, if I exaggerate this, my whole body is going down like this.
You're not
There.
creating any kind of a pull through the ilium on top.
I'm
I
trying.
mean, not, as far as you're not tilting it at all. You're trying to
I'm trying not to, but I mean, you're going to get a little bit. But it's interesting. If I do that, I'm sure that Jeff can feel me side bending him towards the right-hand side. Whereas if I do it same contact, but I make sure I pull like this, more in this direction, he would feel that that was much more minimized. So we can do a kind of, what did you call that this morning? A linear, a curvilinear, yeah, thing. I'm not doing that. I'm just doing a straight linear. And I'm trying to make sure I don't do any curve at all. Yeah. All right, let's do that. And then we have that magical moment of coffee. All right, so we'll try those. Can we now look at the efficiency of rotation, and we'll just sort of use a rotational technique to produce maximum separation in the zygapophyseal joint to start with. And then we'll look at the ability that we have to explore combinations of flexion and extension with a rotation loss and see what we can do as far as the side flexion is concerned. So, this is the classical localization, which you've probably done before anyway. And this is the sort of like standard technique for the rotation manipulation that is done, or the rotational mobilization that is done. Let's just go over one or two very key points with this. Generally speaking, we leave the bottom leg fairly straight so that we can actually do a little bit of fine-tuning rotation of the total body, so that the patient's body and our body can get the right orientation. You know, it's no good as sort of getting him perfect and he's in this position, so we're kind of over in this position. That would be very bad. But say that was his perfect position, I could now hold him absolutely still and just say, let me log roll you towards me so I can retain all of those features. Then I can get into a position and now he's good for me. So this is one reason which would be much more difficult to do if we had his leg bent and so on. So put the bottom leg relatively straight and the top leg we will have bent. Now then, first thing is the whole essence of what I called this morning the classical ligamentous lock of the lower spine, when it used to be thought that it was mostly taking up the slack in the posterior ligamentous system. But as we know, there's a rotation on this as well. So we are actually producing all of the absorption through the facets and so on. Now, what is important is this, that I am going to take the patient up now into a flex position, and let us say I'll come up to 3-4 again. I'm choosing 3-4 not because it's the most usual, but because we've got enough to do below and above to illustrate the principle. So I find 3-4, and the leg has to be in its manipulating or its mobilizing position. That means there's no good as testing it in this position. Now we've got the movement, we drop this down, because now I've gone several joints higher in the back. So for the setup of the manipulation, I'm letting the leg stay in the mobilizing position. And so I arrive at 4, I can feel now 4 and 3 would just begin to move, so I can back off just a little bit. So I know that 3-4 now is in its neutral position. Now I go back to the upper end of the patient here, and what I'm going to do now is to set this up in flexion. So in flexion, I simply take hold of the arm, pull forward and around into this position until I feel the movement, and go down to if I'm doing 3-4, to arrive at 3, but not to move through 3, because if 3 starts to move, 3 is moving on 4. That would not allow me to fine-tune this situation. So now we look and we see what kind of locking have we got in this upper segment. Is it congruent or is it non-congruent? Well, let us just look at the features. We've got rotation to the left, because you were always, not always, but generally speaking, you're taking the shoulder backwards. In muscle energy, you take it forwards, but it just changes which side things happen, that's all. But in the standard procedures, for most things, you're taking the shoulder back, which means you're rotating to that side. So we've got rotation to the left, we can't change that. We've pulled him into flexion, we can't change that. So we now look and see what kind of side flexion have we. And we see that the side flexion is actually side flex to the right. So in the presence of left rotation in flexion, that's got to be the non-congruent locking position. So this would be, in my terminology, and in the terminology of the European osteopathic group, that would be facet locking. Okay? That's what was always called, because it was stiff. But in your notes, Oz thinks that's a little different. Okay, so we're trying to just call this, so there's no conflict, that would be the non-congruent position in flexion. So now I'm in a position to do actually a whole variety of things. I mean, I could distract it, I could side flex it, there's a whole lot of things I could do. What we're going to do is to rotate it. So I can either use the upper lever or I could use the lower lever. We'll choose to use the lower lever. So here I'm going to get hold of the spinous processes of the caudal bones, and I'm going to pull those to the right, which means that the cranial bones, the relative movement, will be to the left. So I'm going to push the spinous processes of those cranial bones to the right, which will produce a left rotation and actually stabilize it for left rotation. So now I just move into that way, and now I can produce my movement as an oscillatory movement. I can do it as a long stretch by just leaning on there like this. Or I can do it by a muscle-based technique to come into this position and just ask the patient now to just very softly resist my push. Okay, now you'd think, golly, what do I do? But in actual fact, they know exactly what to do if you give them the correct information. Now relax yourself. Just let yourself go into the opposite position, and he knows exactly what to do because he's felt the muscle activity. Just resist me a little bit again. So this would be the post-isometric relaxation technique, and let it go. And then if we were feeling really ambitious, we could use the agonistic correction technique. Can you just push forward into my hand here? This is a little more difficult for him. He's not doing quite the right thing here, so I'm giving him the wrong information. That's what I need to know. Okay, just push down towards the ground here. That's not working either. Okay, let me push here. Push down, hold there. Okay, that's a better movement here. Good. Now I want you to push there and pull back with your shoulder. Go on there. So we can actually teach him a mobilizing technique of using isometric correction techniques here, or if I get some movement, an isotonic correction technique, because what he's doing, if I exaggerate it, is he's doing that. But prior to that, I've actually done that and he resisted me, and this is a lot easier for us to do, and this is why post-isometric relaxation techniques are kind of a bit more popular. Just gently, just resist me, and I just stay there and relax. Just let yourself go now. Opposite way, and he comes into a new position. Let's try that again, please. Just hold and let it go, and we go into a new position. Okay, that's nice. So this is the way of doing the classical rotation technique. I could immediately adapt this for doing a side bend technique, because I could come into side bend, hold the rotation that we've got, which is appropriate, and all I've got to do now is to increase the side flexion from this upper component now, and I can do it by pushing down on the ilia perfectly well. So I could do that kind of movement there. Now, I may be counteracted a little bit by the position of the legs, so I can fine-tune this now by asking Jim to push this leg down and then lift this leg up here. No, just bend it, please. That's not changed anything to that position. So now when I come over the pelvis here, I go through that top straight leg, which is a little easier for me to achieve. And now I can do a side flexion technique in this standard position. So it's a matter of either doing this, where I think it's better to have the bottom leg here and this leg bent, and come into this. Or if it was side bend that I wanted to do, change here, come over the top and just go into that side bend position, like that. And there we've got two excellent specific techniques that don't kill you. Now just remember that when you set the patient up in terms of the rotation, then it's important just to look at them in relationship to your orientation, and then just organize yourself. So if Jim's back a little bit and that's his perfect position, I'm just going to ask him, I want you to just retain your body like this, and I'm just going to get contact with you, in which I have to come at the front and at the back, and now I'm going to roll you like a log over like that, so everything is retained, then I hold him, and then I set myself up like this for the fine tune. And so now I have got neutral in this joint, and now we decide, okay, now we're going into flexion with rotation there, or we're going to go into flexion with side bend there, whatever it is we're going to do. All right? So that is the way that we can achieve both rotation and side flexion at that segment. So let's try that, because these are getting very close to being very accurate localization on joints. And then we'll just talk about how we can alter the levers a little bit in terms of putting this in lordosis and that in flexion, as we did when we were in sitting. And you'll see that the same principles occur. And it's not all that difficult. Okay?
David, your only choices there, though, are rotation left and side bending right. You couldn't with that setup
No.
perform any other side bending or different directions of rotation. Could you with that?
I could, but I'm not going to show you it. Having said that, don't put this on, Dave. We could, in actual fact, just come here for a second. I could of two things. Here we've looked at the ability to be able to emphasize rotation or to emphasize side bend. And of course, we've tended to do this more or less in a relatively quiet position of flexion. All right. Now we need to sort of talk a little bit about locking above and locking below in side lying. And if we can translate what we did yesterday into this side lying position, possibly with a few little mnemonics in our head to remind us what to do, it's not going to be so difficult. But before we do that, let's just think about the type 1 group actions or group dysfunctions as spoken about in muscle energy. Group 1s, you remember, are the ones that ostensibly follow Friot's first law, and the first law was related to when we have the joints non-loaded, where side bend and rotation go in opposite directions. So this is neutral mechanics. And these postural problems are found in neutral positions, although very often they get worse as we go to the end of one or the other movements, in the same way as a scoliosis, for example. And I'm not suggesting in any way that we can alter the bony components of a scoliosis, which is to do with bony asymmetries. But if we think of the classical scoliosis, we have a side flexion one way with rotation to the opposite side. That would be a classical kind of type 1 deformity. And we would find that in neutral, although we know that when a scoliotic patient goes into flexion, it exaggerates, or we can see more clearly, the rotational curve, because we get the humps. All right? Now then, if we're talking in terms of like a muscle energy type 1, these are group actions. They've got some really good things in muscle energy. You know, where do you strain yourself? You don't suddenly strain yourself unless you've got a hypermobile segment. You don't normally damage yourself in neutral positions, do you? You normally do it when we're at extreme positions, when the capacity of the body to absorb at that layer is being compromised to some extent. But in neutral, easy things go on. So generally, although it's possible to get nips and traps of meniscoids in neutral, on the whole, this is not the position that we strain ourselves in when we're in easy neutral. But they talk in terms of these postural type 1 problems, which are group actions, where there's an apex, and the apex is where there's the greatest convexity into the side bend, which goes opposite to where the apex is. Now then, I'll perhaps talk a little bit about what they suggest you do with these things, but today I'm going to suggest what we would do with these things, because I think it's a bit more sensible. So we could have Bruce here in a kind of an easy neutral position there, and if I simply think to myself, right, we've got a concavity, or let's go to the convexity. I've got a convexity towards the side here like this. this would mean that the side flexion would be here and the rotation would be this way, because this is where the convexity is shown. So he's rotated like that, and it's gradually got to this, and then it'll gradually reduce as it goes into the thoracic spine. So I'm going to lay Bruce on the side of the convexity, so that the concavity is upper towards me. So to exaggerate the position that he would have, he's going to be side flexed this way. This is his deformity. He's side flexed that way, and he'll be rotated that way, like that, because he's rotated away from the concavity. So that's how he is. Now, I'm going to put him so that this concavity is on the upper side, on the right side in this particular example. And we're going to do a technique that we've just done, okay? Which is, if I roll his shoulder back, that'll counteract the tendency of the rotation to the left, because I'm now rotating to the right. The concavity is towards the right side here, so that if I get on the pelvis and push down like this, I'm producing a concavity towards the left side. So now I've got the correct rotational correction and the correct side bend rotation. And because this is neutral, I'm not really worried about flexion and extension and locking and everything. And it's a group lot of joints anyway, so I don't want to lock to an individual thing. I want to be able to work on a group. Now, we know from the position of the legs that this isn't the best way to side bend. We can do a lot better with side bend to just do that. So here we are. Now, let's think that on the concave side, which is here, we've got some tightness. So I can do a combination now of both specific muscle relaxation and stretching techniques, and also a group of mobilizing techniques of soft tissue. So I'm going to look at these paravertebral muscles, and I'm going to look at the quadratus lumborum on this side, which presumably are shortened because this is the where the concavity is. And I can now get onto here, and I can use a combination of things. First of all, I can use my slow stretches by coming through here.